on the therapeutic potential for PTSD and anxiety, I'd like to introduce Dr. Christine Rabinak. She is an assistant professor of pharmacy practice and pharmaceutical science in the Eugene Applebaum College of Pharmacy and Health Sciences and in psychiatry and behavioral neurosciences and translational neuroscience program in the School of Medicine at Wayne State University. That's a lot of titles. She's involved in several research projects, including investigations of the cannabinoid system as a potential pharmacological target for improving the learning that goes on in exposure-based therapies. Welcome, Christine.
Okay, thank you very much. Before I begin, I want to thank the NIH and its institutes for putting this together and inviting me here to speak with you today. And then also for all of you for sticking around and listening to kind of all of this exciting new stuff that's happening. So first I want to kind of frame anxiety and trauma-based disorders for you and kind of the way we think about them. So anxiety and trauma-related disorders are associated with excessive fear reactions, often triggered by specific objects or situations that in the absence of any actual danger, and often include an inability to extinguish learned fear. So my talk is going to be very similar in structure to Dr. Hillard's in that I'm going to start off with talking about using cannabinoids to alleviate symptoms of anxiety, and then I'm going to switch and think about, is there another way we can target the system to help people that suffer from anxiety and PTSD? And I'm going to focus on the fear extinction. Okay. So over the last 20 years, human neuroimaging has been a powerful tool used to identify brain regions and networks involved in fear and anxiety. What I'm showing you here on the left-hand side is a meta-analysis of neuroimaging studies in humans using tasks that involve negative stimuli. So this might be pictures of scenes, or it might be faces, emotional expressions of fear and anger, threatening stimuli. And what we see consistently being activated to these kinds of negative stimuli is the amygdala. And that's highlighted here kind of in this purple right there. And not surprisingly, in neuroimaging studies, this is also another meta-analysis from patients with PTSD, social anxiety, and specific phobia, is that there's hyperactivity in the amygdala to negative stimuli or these fearful faces. And so it's suggested that this exaggerated amygdala activity might underlie kind of the pathophysiology of anxiety. And so what's really nice about neuroimaging is that it gives us an opportunity to kind of look at the ways that psychoactive medications or drugs might be able to mediate amygdala responding or brain responding to threat and anxiety. So to kind of put this into perspective, I'm going to start with something that we know in evidence-based treatment for anxiety and PTSD is serotonin selective reuptake inhibitors. These are anxiolytics, and they're FDA approved. And if you look at kind of how they might have their anxiolytic effect, here on the left-hand side is a study of an acute SSRI treatment in healthy participants who went into a fMRI and looked at fearful faces, angry faces, or happy faces, and neutral faces. And what you see is that typically what we would expect under placebo conditions, people show increased amygdala activation to fear faces. And this is down here in the bar graph, extracted parameter estimates from this beautiful red activation blob here. But under acute SSRI treatment, this same amygdala activation is actually attenuated by citalopram. So here we've linked, just in this one study, have linked the kind of given a mechanistic target for the effects of SSRIs in this amygdala responding to threat. And more recently, Luan Fan's group has done a 12-week SSRI treatment study in generalized social phobia, in which they did an fMRI scan to a emotional faces processing task in generalized social phobia, and then they did a 12-week treatment with an SSRI, and then brought the patients back and did the same task again in the fMRI. And what they saw here in red is the social anxiety group. This kind of brighter red is pre-treatment. They show an exaggerated amygdala response to threatening stimuli or threatening faces compared to a comparative healthy control group in this lime green here. They compared to them, they show a very exaggerated response. But after 12 weeks of treatment, this response is significantly attenuated. And this is also associated with anxiolytic effects or symptom improvement in these patients. So if we think about cannabinoids as an anxiolytic, a potential anxiolytic, can we take this kind of a model, these kinds of tasks, and can we see similar effects? Would, for instance, THC or cannabidiol or marijuana have these same effects? And interestingly, it is consistent. So here again, Luan Fan had a study where he brought in healthy recreational cannabis users who had, they did another faces emotion task. They were shown faces of fear, anger, and happy. And under placebo condition, they show amygdala activation here. But under THC, this was within subject design, so within the same people, there was no amygdala activation under THC. This is synthetic THC, oral dronabinol. It's 7.5 milligrams. It's the lowest dose shown to have subjective effects as well as alter amygdala reactivity to threatening stimuli. And this last figure here is just a comparison showing you amygdala activation is greater in placebo compared to THC. Similarly, in another study, if you give cannabidiol to healthy participants and they do a faces task, they show decreased amygdala reactivity to threatening faces compared to placebo. So this was basic evidence to kind of show us that cannabinoids could attenuate threat responding in the amygdala and really gives us a target or a mechanistic approach to looking at this. There is very limited data, but there is a study here looking at this in anxiety patients. So what I showed you is all healthy people, right? And that's not the problem. Healthy people aren't the problem, right? So here, if you give cannabidiol, not only do you see a decrease in anxiety, so this is again that visual analog mood scale here, and so pre-treatment, patients with social anxiety report high levels of anxiety or discomfort. And time zero is when they're administered the drug. And over the duration of 140 minutes, you see that cannabidiol is significantly decreasing anxiety compared to a placebo condition. And this is associated with decreased activation in the amygdala. And this is just a resting state. So this time we're not even activating amygdala with a threatening face. So just in basal conditions, we can alter amygdala reactivity. This is consistent with a resting state study in citalopram in patients, in that you see decreased activation in this limbic system in citalopram compared to placebo. So there's a lot of overlap between these two kinds of studies here, and it's very promising. We know that people who utilize cannabis for anxiety or PTSD report using it to decrease symptoms of anxiety, improve insomnia, improve mood, and so it seems to be very effective, right? Well, it's not entirely the case. So we heard in the last talk that THC, for instance, has biphasic effects. So while it can be anxiolytic, it can also be anxiogenic. So there are studies that have been conducted, similar to Luan Fan, that have used higher doses of THC and not found any effects on amygdala responding, and actually found increases anxiety-type responses. So it's complicated, like everything we've heard today and yesterday. So some really exciting things. This kind of goes related to the last talk that Dr. Hillard brought up about individual variability in this system and how it might be a risk factor for developing anxiety or stress. So these are two studies that are looking at a common variant in the Fa gene. So we assume that if they have this variant, they have less Fa and increased anandamide circulating in the system, which means potential for increased anandamide in the brain. Unfortunately, unlike rats, we can't really measure it directly in a human's brain yet. But so what we see here is that, again, to a task where we show threatening faces, we see in people that have this A variant, A carriers, they show a decrease in amygdala activation. These are healthy people. to threatening faces that have this variant. And so, whereas the C homozygotes show an increase in amygdala activation. This study on the right-hand side is similar, only now it's showing you the amount of amygdala habituation to threatening faces. So the higher this bar, the more habituation or attenuation of amygdala activation. So very, again, replicated. And this is important that we're able to replicate these findings. So I want to summarize, give you a summary of just these first couple studies. What we know in humans, evidence-based, is not as much as we know preclinically. Okay? So what I showed you is basically what we know. So acute exogenous cannabinoids modulate amygdala reactivity to threat. Increased endocannabinoid signaling is associated with lower amygdala reactivity to threat. And something I didn't mention before, but there is a study that has looked at the Fa variant in PTSD and has found that that was associated with threat symptomology in PTSD. So the C allele variant, or the C homozygotes, was associated with increased re-experiencing symptoms in PTSD. But that's one study that's been happened so far. So what do we still need to know if we consider THC cannabinoids as a potential anxiolytic, just like SSRIs? Well, I think this first question is a really important one that we need to seriously think about, is how would long-term treatment with exogenous cannabinoids affect anxiety patients? The data that we have so far is just acute. We don't have a long-term clinical trial giving this repeatedly over and over again to people. And we heard in other talks that chronic use could lead to downregulation of CB1 receptors, which has been associated with a depression-like phenotype and increased risk for addiction. So I don't want to treat one problem and create another one, right? The second one, if people with a certain genotype in this Fa receptor, could we give a Fa inhibitor to restore low levels of anandamide back to normal, thus maybe hopefully alleviating some of these symptoms? We don't know. We haven't used the Fa inhibitor in patients yet. We don't have published data on that. And lastly, how might other cannabinoid compounds affect fear processing brain activation? Most of these studies are done with pure compounds of either cannabidiol or THC. We don't know about other effects of all the other things that might be going on in marijuana. So I'm going to switch now. You know, my issue with treating symptoms of anxiety is that it's not necessarily getting at some of the root problems with PTSD and anxiety, which is this inability to extinguish or inhibit fear responses. And treating just the symptoms of anxiety is really no different than an SSRI, right? We're just treating symptoms, but is it something that they have to do for the rest of their lives? They have to keep smoking every day? What I'm going to ask you to do is step out of the box with me and think about this, targeting the system in another way that hopefully will give patients control of their lives again. Isn't something that they have to depend on in order to feel better, but is very targeted, and there's some evidence for. So like I said, PTSD and anxiety disorders can be conceptualized as a failure to appropriately inhibit or extinguish fear. Primary behavioral treatment is exposure-based therapy. How does this work? Well, just like this cartoon. Here, Mrs. Snyder she's got a specific phobia to thunderstorms. So what her therapist is doing is throwing lightning bolts at her over and over again without actually hitting her to try to reduce her fear of thunderstorms. And so while this might be a little exaggerated, this is basically how it works. We're trying to extinguish a fear response to cues that really they shouldn't be afraid of. Although in this case, she might want to be afraid of lightning bolts. Okay, so we can use Pavlovian fear extinction like was described in animals in humans to kind of model this type of learning and look at this underlying dysfunction in anxiety and PTSD. And this is an example from a collaborator of mine, Mohammed Malad, who really was critical in kind of creating this paradigm, translating it from animals to humans. And briefly, this is what we do. Day one, we do fear conditioning with people. We teach them that a particular color light is paired with a mild wrist shock. So what we measure as like a fear response, for example, in these studies is changes in skin conductance. And so that's basically like a sweating response in your fingers. So that's what we use as our index of fear. And so after repeated trials, people learn that, oh, when that blue light comes on, I'm going to get a shock. And so now that blue light takes on properties of the aversive stimulus, and people show increased skin conductance or conditioned responses, as shown down here in the schematic, to that cue, even before they know whether or not they're going to get shocked. We bring them back and we can do extinction learning. So now we're going to say, okay, listen, that light's okay. It doesn't mean something bad, so we're trying to teach a new association. This isn't unlearning of the first association. This is a new association. Early on, in extinction session, they show high levels of fear, but as we consistently and persistently show this light to them in the absence of anything bad happening, those fear responses go down or extinguish. And we can test how well this works by doing an extinction recall test at a later time point. And so we show them the cue again in the absence of anything bad happening, and we're basically asking, how are you going to respond? Is the fear memory going to win and you're going to show high fear, or are you going to show very good recall of extinction learning? And typically what we see is good extinction recall, low levels of fear in people. However, in pathology, in like PTSD, for instance, we don't see that. They show this kind of recovery of the fear response as if this session never happened. They can do the extinction learning within session just fine, but it's the maintenance of that. So it seems to be very specific to this recall process. And we know, and this was brought up before, by using this model in neuroimaging, we have been able to identify brain regions that are involved in this ability to recall the extinction memory process. And this primarily is the ventral medial prefrontal cortex, here shown in the sagittal slice from a human brain. This is important in cognition and fear extinction recall. And also the hippocampus, here in the green circle, in this coronal slice. This is important for long-term memory consolidation as well as fear extinction recall. And not surprisingly, people with PTSD have deficits in the ability to recall extinction as well as decreased activation in these brain regions compared to healthy controls or traumatized non-PTSD patients. So, based off of the animal literature that we just heard about with, using this to try to enhance fear extinction learning, I kind of was thinking about this like, well, maybe we can do this in people. Let's see what happens, right? If we can find an agent that reverses VMPFC or hippocampal dysfunction, maybe we can reverse that impairment in the ability to extinguish fear and actually make therapy better. So in 2013, the study came out, and we asked the basic question, can cannabinoids facilitate fear extinction in humans? So we had a hypothesis based largely off of the animal literature. This hadn't been done in humans before. So if we gave a pre-extinction administration of an acute dose of THC, we expected to facilitate extinction of conditioned fear responses compared to placebo. So in a double-blind, placebo-controlled study, what we did was a fear conditioning study, very similar to what I just described. Here we showed different colored squares paired with an aversive white noise burst. On day 1, fear acquisition. Day 2, we brought everybody back, and we administered either low-dose THC, again, dronabinol at 7.5 milligrams, or placebo. And then 2 hours later, we did the extinction learning test. 24 hours after that, we brought everybody back and we did a recall test. And I want to note here that this is important, that THC was only given during extinction learning, not during the recall test. So what did we see? Well, during extinction, we saw no effect of THC on within-session learning. At early extinction, this is mean skin conductance response to the cue that was previously paired with the white noise. And we see high levels of fear in both THC and placebo. And by the end of the session, both of those levels are low and there's no significant difference. If we look at this trial by trial, there's no difference in the rate of extinction. So THC is on board, but it's not actually interfering with this learning process or enhancing it. And I want to note, too, that we, like in the pain studies, we take a lot of measurements about subjective effects and do you feel anything? And most people that receive the THC assume that they're on placebo. So it's a very low dose, and they don't really feel any subjective effects. And these aren't necessarily people that have used cannabis before. So some of these people are naive to it. There was only one person that received placebo that thought he was on THC, and it was a really uncomfortable debriefing, unblinding of him. So what do we see during recall? Well, we saw something really exciting. We saw something that was consistent with the animal literature. In those people that had received THC during extinction learning, we saw decreased skin conductance response to the cue that was extinguished compared to people that received placebo. They showed some spontaneous recovery of fear. So from this study, we had concluded that participants that received placebo during extinction learning exhibited spontaneous recovery of fear to a condition cue that was previously extinguished, whereas THC attenuated this response. THC didn't affect within session learning, but it only influenced the ability to successfully recall extinction memory when compared to placebo, suggesting that THC affects the ability to maintain and or successfully retrieve extinction memory. So we had kind of broadly concluded from this pre-extinction administration of an acute dose of THC facilitates extinction of conditioned fear in humans. What does it do to the underlying neural circuitry? We replicated this study in a separate group of people in the fMRI scanner this time. And what we found was that people that had received THC during extinction learning, during the recall test, showed increased activation in the VMPFC and the hippocampus compared to those that had received placebo. So this here, we had concluded that pre-extinction administration of THC modulates underlying neural circuits involved in fear extinction in humans. We were very excited about this data because this shows some promise for us. And just another thing really quick is that individual variability in that FA gene in just healthy, non-pathological psychiatric conditions influences the ability to learn this extinction or acquire this. So people with that CC homozygotes here, they show poor extinction recall. And people with a variant in the cannabinoid type 1 receptor also show poor or don't even extinguish. So this could influence their ability to respond to the treatment. So to summarize, I just have 2 slides. What we know from this study is that pre-extinction administration of THC facilitates extinction of conditioned fear in humans. It modulates the underlying neural circuits involved in fear extinction in humans. Individual variability in ECB signaling is associated with fear extinction learning success. So what do we still need to know? So can we rescue behavioral and neural deficits of fear extinction recall in PTSD anxiety disorder with an acute dose of THC? I'm doing that right now. I don't have results to say which way it's going to be going, but we have a funded study for that. So hopefully in the next year I'll be able to tell you. 2, what other cannabinoid targets could facilitate extinction? So we've heard that perhaps direct activation with THC might not be the best choice, and because of its psychoactive properties, could be difficult to work with. So there are FA inhibitors, there's cannabidiol. I haven't worked with those yet because I haven't been able to access them. So hopefully that will change. And then lastly, can cannabinoids facilitate extinction-based exposure therapies? And hopefully, if this is funded, I will be able to tell you about that as well. So we will be taking this to a clinical trial. So what are some things that we still need to know? Long-term impact. What's the optimal dosing and timing of treatment? And then is there a therapeutic potential of cannabinoids for anxiety treatment in children? Anxiety treatment in children with pharmacological agents is very touchy in that we get increased suicide rates. And so this would be great if it could be another option, but as we've heard already, there are a lot of things to consider. So I just want to acknowledge our funding sources and all of my collaborators and my research staff who is key in collecting this data. Thank you.
So we're going to get all of the speakers up to the stage. Thank you for that talk, Dr. Rabinak. That was great. So we can start off with a question from I'm getting it on the screen, but not up there, from Twitter. Okay, we'll read it. Oh, there we go. So this is to Dr. Homan. There are many CB1 and CB2 receptors in human skin. Do you believe topicals have a place in localized pain relief? Something pain relief? Localized, that's where we're all going to go with? Okay.
Yes, there's good evidence for peripheral cannabinoid anti-nociceptive mechanisms. I think that some topical products are still under development. I don't recall seeing much in terms of published clinical studies or clinical trials to see efficacy, but I think there's therapeutic potential that should be evaluated.
Another one for Dr. Homan. What were the characteristics of the subjects that responded to Sabrex within the pilot and with chemotherapy?
Yes. That's actually a really good question, and unfortunately I don't have an answer for that question because this was a pilot trial and a small number of subjects. The subjects differed on many parameters. They had different chemotherapeutic agents. They had different histories of prior medication for chemotherapy-induced peripheral neuropathy. Also, it's very important to point out that in a study like that, you're basically recruiting subjects who have not received benefit from other therapies. So it's a very difficult population to even see efficacy in. So we just don't know at this point.
Okay. Dr. Wilsey, sorry. As we re-examine the use of opioids for the treatment of chronic pain, there's an increase in the use of cannabinoids. Do we know enough about the side effects, potential impairment, drug interactions, and long-term effects of cannabinoid treatments to move forward so quickly?
I don't think we know enough. I think there has to be more investigation. We've prepared a cannabis use agreement, or similar to an opioid use agreement that has been in play in many pain clinics for years, telling people the side effects of cannabis, and advocating the lowest dose, advocating that they consider getting a mixture of a high ratio of CBD to THC. This is conjectural on our part to have said this, but hopefully there'll be more evidence coming out how to reduce the psychoactivity and the neurocognitive deficits that are produced by cannabis. You know, it's the problem with opioids, as you know, is that there's this inadvertent overdose from opioids, and that's because the opioid receptors are in the midbrain near the respiratory center, whereas cannabis doesn't have any cannabinoid receptors there. And I think that's why we've had this stage now where we've usually had just a recommendation to use cannabis, and we allow people to go to a dispensary and have somebody behind the counter recommend some ridiculous combination. We've got to learn more so that we can actually prescribe it. And I'm not saying that I'm sure it's going to be FDA approved. There are only two herbal medicines that are FDA approved currently that I read in Dr. Volka's blog. But I think there'll be interest, especially when cannabis is no longer Schedule I, with pharmaceutical companies coming into the fray. I've heard that from representatives of the pharmaceutical industry. So I think the future's there, but again, this comes with the warning that the side effects may be prohibitive.
Thanks. Another question from Twitter. Dr. Hiller, do you know about the mechanism that causes paranoia in some individuals when they smoke cannabis?
Yeah, that's a really good question. There certainly are biphasic effects of cannabis smoking, such that in naive users or in users who are exposed to very high amounts, and this turns out to be particularly problematic in oral cannabis use because the onset of action takes a while. Someone eats half of the cookie or brownie and says, I'm not feeling anything, and then eats the other half and winds up feeling very badly. So there can be pretty strong psychological changes that are associated with paranoia. Very much the opposite of kind of what we normally consider to be the anti-anxiety and reduction of fear effects of the cannabinoids. I think there's multiple explanations for this. One is that as we've heard, the cannabinoid receptors are on both GABAergic and glutamatergic terminals. And just to think of this in a very simplistic way, glutamate is pushing on the accelerator and GABA is pushing on the brake. So if we're modulating both of these by flooding the brain with an agonist, who knows what's going to win in the end. And clearly the ability to engage receptors on glutamate versus GABA terminals is very much dose related. So as you get to very high doses of THC, you tend to produce effects that are much more dysphoric than one gets at low doses. So the mechanism is all the same. It probably is all CB1 receptors. It's likely a differentiation in the site in the circuit perhaps, or the cell, the neuron, or the excitatory versus inhibitory neurons that are being hit by that drug at that concentration and dose.
Dr. Rabinak, quality exposure therapy requires attention be directed to the fear stimulus. How might THC's negative effects on attention impact exposure therapy?
That is a great question. So one idea of why exposure works is that you want to elicit the maximum amount of anxiety that the patient can withstand without bailing from the treatment. And you slowly work up a fear hierarchy from there. And so we don't really want to mess with their ability to feel those anxiety-type symptoms. So, one idea, and I don't know if this is quite the answer you're looking for, but is trying to utilize a very low dose of THC, or maybe not even going the THC route, going one of these other routes instead, to kind of not interfere with the process of the exposure therapy. If it does and they can't attend to it, they're not going to see the benefit from the therapy.
For both pain and PTSD, has there been any study across the lifespan about how the therapeutic effects may differ in young children, teens, adults, and then older adults?
Not that I'm aware of.
No, I'm not sure it's even been done in animals. Certainly hasn't been done in humans.
Is there an epigenetic modulation of CNRI in animals under stress?
Great question. As far as I know, there's no evidence as yet, at least not published evidence of an epigenetic change.
One final question for Dr. Holman. Does Sativex produce any side effects on rodent models and humans? Does Sativex produce any side effects in rodent models and humans?
Well, we're using the side effects that are observable and measurable in animals, such as motor impairment, hypothermia, ataxia, tail flick anti-nociception as signs of CB1 activation. And those are parameters that are easy to measure in animals. Of course, side effects in humans are more profound in terms of the psychoactivity or dizziness, and it's harder to measure that in animals.
Great.
But that's also CB1 mediated.
Great, and we're going to have one more question from Twitter. Can we compare SAE of opioids to that of cannabinoids through existing separate studies? Can we compare SAE of opioids to that of cannabinoids through existing separate studies? Significant adverse effects, I think. Yeah.
Well, sure. I mean, opioids can produce, or maybe, Bart, if you want to tackle this one, but opioids can produce very serious side effects. I mean, obviously, respiratory depression and lethality can occur, undesirable for therapeutic intervention. Constipation is nearly universal. Tolerance, opioid-induced hyperalgesia, and of course, physical dependence. And so I think cannabinoids, even by contrast, if you look at withdrawal from opioids compared to withdrawal from cannabinoids, the cannabinoid withdrawal syndrome is milder, clearly, and it lacks a lot of those pronounced autonomic signs, at least what we see. So I would think that the serious adverse events are even greater for opioids.
I'm not sure I can compare them. I mentioned that study by Mark Ware in Canada that over 200 patients who were on cannabis didn't have increased incidence of serious adverse events compared to the control patients, the people who were not on cannabis. I would remark that in the case of opioids, numerous opioids have undergone FDA approval. So they have numerous studies involving administration over 8 to 12 weeks. Now we know that people have inadvertent overdoses, and there's certain reasons for that. If somebody has a history of addiction, if somebody has a serious psychiatric illness, they're more likely to have a inadvertent overdose. But in the studies that were done before this became apparent, before inadvertent overdose became more problematic in terms of fatalities than motor vehicle accidents in this country, we had a lot of studies that involved FDA approvals on opioids, and I didn't see this problem. In fact, during my 20-year career in pain medicine, I was not aware of this problem until Pelosi at the CDC discovered the overdosing was now from opioids. So that's not that recent, but I was kind of shocked. They're not that safe. In fact, the CDC is now saying, at least to primary care doctors, try to use physical therapy and cognitive behavioral therapy and try to avoid opioids. In my experience, that's been difficult because insurance companies won't pay for physical therapy and cognitive behavioral therapy. So the CDC director is trying to change that, and I hope he does. I still see that, I've watched the pendulum swing from when I was a medical student, when we wouldn't give an opioid to a young woman dying of cervical cancer because she might develop tolerance to it and might need it later. And that's a true story 40 years ago. And then the pendulum swung during the 80s and 90s where we were giving it out like holy water in the pain clinic. And now we're back to being very careful with whom we're giving it, trying to choose patients who don't have, as I said, histories of addiction or histories of serious medical, psychiatric illnesses, and watching people more closely, doing urine toxicology screens, doing these surveys that we give that point out a propensity to abuse opioids. But I think there's always going to be a place for opioids, and now I'm hoping that cannabinoids can be used in conjunction. I can see somebody, we've been talking about PTSD here, I can see rational therapy where somebody with PTSD might use cannabis just in the evening to help treat their insomnia, help them forget. What medicine is there better than an opioid, than a cannabis to forget something?
I'd like to thank everybody on our panel and turn it over to Dr. Stein for announcements about lunch.
Great. Thank you, panelists. Same routine for lunch. We'll be back here at 1 o'clock.